har vi fått en liten video inn som på impuls her. Det en video om samstemming av legemiddellister som kommer fra Nordlandssykehuset. Vi kjører den nå.
Har du liste over medisinene dine? En oppdatert medisinliste bidrar til at du får riktig behandling av legen din og på sykehuset. Ved fastlegen skrive ut en liste over alle medisiner du bruker. Ha alltid listen med deg og vis fram listen til sykehuset, hjemmetjenesten, legen, tannlegen og på apoteket. Medisinlisten kan redde livet ditt.
Ja, denne videoen laget i forbindelse med en kampanje vi har hatt om medisinliste, som vi har laget i samarbeid med Legemiddelverket. Og noen av dere kjente kanskje igjen den fortellerstemmen som var i bakgrunnen. Det altså Morten Finknagen, som sitter, det den høye mannen som sitter midt i salen her. Bra jobba, Morten. Da går vi videre. Nå har vi forsøkt å prioritere ideene våre, og vi har tenkt på hvordan vi kan konkretisere dem og få dem ut i praksis. Og for å lykkes med det, så vi helt avhengige av å forankre arbeidet og få med oss kollegene våre, og sikre at dette ikke bare noe vi gjør på en avdeling. Og den beste til å si noe om forankring, ledelse av forbedringsarbeid og spredning, det Maureen Bisignano, som dere ble kjent med i går. Maureen, I'm saying that I'm sure that everyone has learned a lot over these past 2 days. We have the will, we have the ideas, and we need to discuss further successful execution. And we hope that you can help us with this. So the stage is yours.
Thanks. Well, thank you so much for everything that you've done. I truly will return back to the United States impressed with the fact that we had 750 people here, all teaching, all learning. I loved the examples that you're building of things that you're going to do by next Tuesday, and hope the energy continues. I wanted to, yesterday, start by talking about what you might do, and today to talk a little bit about how we can begin to spread ideas. But I thought I would start this afternoon by talking about why I care so much about patient safety. I know you probably all are here because you care just as much as I do, but my reasons are personal, and yours may be too. I am the oldest of 9 children, a big Irish family, and we're all very close. The farthest we live apart from each other is 20 miles, and so we're always all together. When Easter comes in a few weeks' time, everybody in my immediate family will come to my house, and that means there'll be 51 people having Easter dinner at my house. That's my immediate family. But I care so much because there should be 52. And the reason I care is because my nephew, Robbie was the first one of the grandkids to be born. He was born to my sister. And he was the most loved kid you could ever imagine. Robbie was healthy and vibrant, and you can picture in my family that he never got into his crib. He was always being passed from one aunt or uncle to the next and never got a chance to lie down. When Robbie was 2 months old, my sister took him to his doctor, and the doctor said after his physical exam, Robbie's perfect. Well, we already knew that he was perfect, but he said that he's perfect. And at the end of his exam, he said, I'm going to give him his DPT vaccination, which he gave to him. My sister is not in healthcare, but when my sister got Robbie home, she started to notice that he was having some symptoms, some twitchiness and some difficulty breathing. So she brought him back to the doctor, and they ended up putting him in an intensive care unit. And Robbie was very, very sick for a week in an ICU. He started to get better, and then finally came back home, fully recovered. I took this picture when Robbie was 4 months old. And again, he was the Robbie that we all knew and loved. When Robbie turned 4 months, the day after I took this picture, my sister took him to his doctor again for his 4-month examination. And the doctor said, Robbie is perfect. And then he said at the end of the visit, I'm going to give him his DPT vaccination. And my sister said, don't you remember what happened the last time? And the doctor said, no. And my sister said, you gave him the shot, he had a reaction, he was in the ICU, he almost died. And the doctor said, that had nothing to do with it. And then he thought for a moment and he said, I'll give him a half a dose. So he gave Robbie a half a dose of the vaccination, and Robbie died within 24 hours. And my sister said 3 things to me that day that changed my career. The first thing she said is, why do you keep the medical records for the doctor's office one place and the hospital another place? She said, if the doctor had access to those medical records, I think he would have put 1 and 1 together to make 2. The second thing she said is, why didn't he, because she looked it up on the internet afterward, she said, why didn't he know that you don't give a half a dose if someone's had an allergic reaction? That was the way he used to do it when he was practicing medicine in his early years. But research had changed and proven that that's not the best thing to do. But his practice hadn't changed. And I tried to explain to her how difficult it is for doctors and nurses to keep up with all of the new research that's coming out every day, every week. And then the third thing she said to me is, why didn't he listen to me? And those 3 questions changed my career. I went from being a nurse taking care of patients to thinking I also have an obligation to fix the system. A lot has changed since Robbie died. We're starting to see people define harm in different ways. You're here talking about harm that didn't even have a name a few years ago. You're talking about decreasing complications that we used to think just happened, but now we know it's our responsibility to fix them. We can measure safety. I'm hearing you talk about and seeing charts and graphs as I walk through the meeting of you making progress in making care safer. We can predict problems and prevent them. I'll show you what some of that looks like. Transparency, you knowing that you're better or not so good as another unit in the hospital or another hospital in the system, inspires you to have curiosity, to go say, maybe I can make things better. We're seeing teamwork, and teamwork is so critical. We're seeing change packages. So much has changed, but we still have a long way to go, and that's why I'm so grateful to all of you for being here today, for writing out your PDSA cycles for next Tuesday, and for everything that you're going to do when you go back to prevent another baby from suffering like that. We still have so many challenges, assuring quality for every patient every time, leading improvement to close the gaps that we've got. We still have so many challenges today, and yet so much I've heard you thinking about tomorrow. I've heard so many times these days people saying, well, in 10 years' time, I'm going to need to do this. Or in 20 years' time, so many people I care for are going to be elderly. I love that you're thinking about prediction and prevention. But we still have a lot of work to do, and I think a lot of it comes down to the joy that in our workforce, the learning systems. So what I want to do today is talk a bit about how the challenges we have and how I think we can best overcome them. In the best organizations, I'm seeing that the leaders are embracing the genius of the and. Many of you have said when you go back, you're going to hear people say, but no, I can't do that, I can't do that. And we're asking you to say, I can. And the way that you can do that is by the genius of the and. It's not medicine or administration. It's not doctors or nurses. It's thinking about when someone says or, for you to say, let's think about and. Because the tyranny of the or, it's me or you, it's win or lose, just sucks the energy out of a room. And when you go back, you're going to be change agents. You're going to be thinking in a totally new way about how do you build the will for change, where are you going to get the ideas, and then how, as Anna Greta was saying, do we execute, implement as we go forward. So I've been talking to some folks here today about high-impact leadership. And we've been talking a lot about culture. I've heard a lot of you talking about culture. And how do we create an inspiration, a commitment to patients that Robbie's younger brothers will be safer, that all of our family will be safer in the next generation? And it requires three things: building will, coming up with new ideas, and then using quality improvement methods to implement them reliably. So I want to spend a few minutes, give you some ideas on how you might think about building will, harvesting new ideas, and how do you actually implement. Building the will for change. The group I was talking with of leaders upstairs, I was saying that sometimes when you go back from a conference like this, your temptation is what we call wet dog syndrome. You go back and you're so excited that you start saying, I learned this, and people look at you like a wet dog and they run away because you're shaking off all your ideas and they're running so that they won't get wet. And so when you go back, think about, how will I build the will for change? How will I help people to understand what I have seen, and then how they might use those ideas? In the old days, the idea was fix and forget. When you walked onto a unit, if the supply wasn't there or the medication was wrong, your inclination was, as an individual, was to go, you kind of grumble a little bit, but you fix it for that patient, and then you forget and you move on. And all day long, you're running into these fix and forget kind of scenarios. It can take the energy away from you. But what we're going to do today is move from fix and forget to see, solve, and share, so that you might see a problem and you solve it for that patient. But we'll build ways to share those problems so that somebody will fix the system for the whole, so that it isn't every single day coming in and solving the same problems, but you're building the will by see, solve, and share to solve the problems for all. One of the best ways to build will, I think, is to connect with people personally, to talk with people about stories. And so I brought along a little video. The story behind the video is this. There's a hospital in the United States which has one of the best reputations. It's called Cleveland Clinic. It has the same kind of a reputation as Mayo Clinic, as Mass General Hospital. And one day, the CEO was standing up teaching a class like this at Harvard. And he was talking about all his outcomes. He was showing graphs and charts about how good they were. And he was getting all this affirmation from people saying, you're the best hospital. And this CEO was kind of walking on air. And he saw somebody in the audience who looked familiar. And in the end, he found that this was a nurse leader who works at Cleveland Clinic. She worked for him. And what she was thinking about, her face was puzzled because she said, my father has a serious disease and he needs to have surgery for his cancer. And she said, I'm trying to decide where to send him for his surgery. And he said, well, why aren't you sending your father to Cleveland Clinic? We have the best cancer outcomes in the country. And she said, there's no empathy. And so he made this video to build the will for change, to say we can't only be clinically excellent, but we've got to understand the family. And I think the idea here is that sometimes stories really help us to motivate. Who do you remember? Is there somebody that sticks in your soul? Take a minute and talk to someone next to you and say, which one of those patients, a happy, a sad, a professional, or a patient, stuck with you? Take a minute. Okay, let's come back together. I know that what I can tell you is that this video has changed the culture at Cleveland Clinic. It made people stop and think in a very different way. The person I'll tell you who sticks in my mind is the elderly woman, and it says she doesn't completely understand. And she just sticks in my heart. I think about her all the time because I can imagine a doctor or a nurse or a pharmacist going in and having a whole conversation with her, and yet she doesn't completely understand. So I think the idea of telling a story, of building the will, is something that hopefully you'll think about when you go back, that people are so busy. You saw how stressed some of those caregivers were. The nurse who's ending a 12-hour shift and looked really tired. And so when you think about it, we've got to take care of the caregivers as well as the staff. And if we just keep in our busyness with our heads down, we'll never really have that empathy. We won't be able to build the will for change. There is a second Cleveland Clinic video if you're interested. And I would recommend that you just go onto YouTube, and it's a follow-up to this one. And it's similar in that it's a patient telling a story about a surgical procedure, another woman talking about being diagnosed with breast cancer. And what you see is similar stories that require people to have empathy. And then at the end of the video, you see all of these people in a different setting. And you realize they are all, in addition, caregivers, doctors, nurses, receptionists at Cleveland Clinic. So it just blends the role of caregiving and care needing so well that I think I would encourage you to go back and think about tomorrow or the next day when you go back to work, what might it be like when you're sitting around a lunch table to tell a story? When you look out and you see someone who's in distress, whether it's a patient or a caregiver, a colleague, how can you stop and find out how you can best help? So think about building the will for change. The second is ideas. And where will you get those ideas? Hopefully, are going away, I know you are, from your sheets of paper with a dozen or so ideas that you could implement today, tomorrow, to make a difference for your patients. But think also about how consciously you get ideas. Think about this as a separate little job. That when you're out and you're talking to someone, when you're walking onto a different unit, how can you pick up an idea? Because those ideas are the germs of you going back and planting a seed that will produce a better outcome. An example, some ideas worth pursuing. One is the thought of minimally disruptive medicine. One of my friends, Victor Montori, talks about minimally disruptive medicine because he says sometimes cancer, heart disease, chronic obstructive lung disease, sometimes the disease is so challenging that he says, I can't do anything about the burden of the disease, but he said, I can do something about the burden of the treatment. And so when you start to follow a patient through an episode or a visit or a hospitalization, you'll get ideas about how you might be able to change things. what he says is minimally disruptive medicine takes into account that the patient has a lot on their plate. An example is this is the work of being a chronic patient. They have meds, they have diet, they have exercise, they have visits, they're trying to get transportation. There's lots going on in the patient's lives that we might not even see. And we just say, oh, come in for a visit. And then next week, come in for another visit and get your blood drawn now so that I can have the results when I see you. Do you know what this is? 5,000 hours. 5,000 hours is the number of waking hours in a year a patient with a chronic disease has that they're taking care of themselves. 5,000 waking hours in a year that a person with a chronic disease is caring for themselves. You might see them twice a year for a 15-minute visit and once for a hospitalization. So if we think only of optimizing the visits and the hospitalizations, we're missing one of the biggest assets, which is those 5,000 hours. You might think in a different way about the way that you work together as a team. At one of the hospitals that I work with in the United States, called Theta Care, they decided that they were being disruptive to a patient on admission. So they watched the admission process. Somebody would bring the patient into the room. Often a nurse would come in and they'd say, okay, what's your name and what are you here for? And they would do vital signs and all. And then they would leave, and then sometime next a pharmacist might come in, and then a social worker and a doctor, and then it all starts over again. They said it's so disruptive because we keep asking the patient the same questions over and over again, and the patients are exhausted just trying to take care of us. So they created collaborative care. Every patient that gets admitted by a team, a doctor, a nurse, and a pharmacist. Within a few minutes of them coming into their bedroom, the team comes in, the pharmacist runs the admission, and the pharmacist orchestrates all of the questions and answers. The nurse is making a daily plan on a whiteboard in the room, and the doctor is doing the first interview and creating the collaborative strategy. These collaborative rounds weren't easy to implement because at first the doctors were saying, well, I don't want to have to be with someone when I go and admit my patient, and I don't want to change my schedule to do the admission when the pharmacist is available. But now everybody in the hospital would not do it a different way. It's saved phone calls and calling to clarify. It has actually decreased the length of stay for every patient in this hospital by a day. So that's about 25% decrease in length of stay. It's improved communication. It's improved patient satisfaction. So if you want to think about decreasing the burden on a patient and creating joy in the workforce, you might think about something like collaborative care. And then using data to predict. So many nurses and doctors tell me that they feel helpless. They feel like they never know what's going to happen tomorrow or this afternoon. And so they're always being called into emergencies. This is a hospital in New York, and if you ever get close to visiting Boston or New York, let me know, and I could make an arrangement for you to go visit here. It's breathtaking. They have a room that's called a command center that's about like the first 4 rows up to here of this wide room. And they have a big screen, and it's a moving map of all of Manhattan and Long Island. And they use all of their historical data to understand who lives in every neighborhood in the city. So they'll know this apartment building, as an example, has elderly Japanese people, and they come out to do Tai Chi at 5 o'clock in the morning. This wall is a moving weather map, and if the people sitting at the console look at data and they see an ice storm moving in, they will send an ambulance to that neighborhood because they can anticipate that someone will fall. They don't know the name of the patient, but they can put an ambulance in a neighborhood reliably by using their historical data. So they are watching an ice bridge that's freezing, put an ambulance on the other side. Or we have a new demonstration, Occupy Wall Street, and they'll put ambulances at every place where they can access people who are going to need care. They know the demographics of the apartment building, and it is so fun to sit there and watch them anticipate and predict and get those care sites out there reliably before anybody calls them for help. It's decreased the response time, of course, improved resuscitation rates, and the staff find joy because they're not responding all the time to something unanticipated. They're expecting and moving in a completely different way. They're working on sepsis, anticipating when a patient comes into the emergency room, anticipating what the sepsis kit might look like, and how do we, just like you are, get that kit into the hands of the doctors and nurses so that they can respond quickly. So think about, how do you build will? Think about, how do you get new ideas? And there are hundreds floating around this room. And then think about execution. How do you build improvement skills so that a doctor or a nurse, when they see a defect or a problem, can actually get in and make that fix? The IHI Open School we've talked a little bit about is an online way to build improvement capability. And you have access to that. You could talk to Anna Greta about that. Every medical student, nursing student, pharmacy student, every faculty member has global access to this for free. And we have right now 400,000 people taking these courses online and building their improvement capability. They can use the model for improvement to solve any problem, predicting ambulances, dealing with sepsis, working with empathy, helping to decrease postpartum hemorrhage, all the things that you're working with. So think about how you might build the improvement skills of the people that you're working with so that you can reliably get going on the implementation. But the challenge of the triple aim, and we've been talking a lot about this, I've been talking with you about it at breaks and at lunch, thinking in a different way about what the challenge of improvement is still big. And so you will need to think about, how do you get new ideas? As I mentioned yesterday, we think about new ideas in two ways. How can we bring new ideas to healthcare? And how can we bring new ideas to health? In the healthcare side, I showed you the Leadership Alliance Radical Redesign Principles. And this is what yesterday I was asking you to make a copy of and stick over your desk so that when you run into your next problem, you can look for a radical redesign principle and find an idea to implement. One of them is about making it easy. And when we sat with one of our faculty members, a woman named Kristen Lind, she has a son who has severe developmental health and social challenges. And we asked her, what does it look like for you to take care of your son, Gabe? And she tried to explain it in words, but when she made this map, it transformed the way that we thought about healthcare. That's Gabe in the middle and her family. But she said, these are all the other people I have to interact with on a daily, a weekly, a monthly basis. And when we saw the complexity of that map, we realized as healthcare people, it was our job to help her make it easy. When I was in Singapore recently, one of the leaders there, I was talking to him about making it easy. And he said this: the sicker the patient, the fewer professionals they should ever have to interact with. The sicker the patient, the fewer the professionals they interact with will take on the burden of coordination. And I loved that because that's uncommon. In most places, the sicker you are, the more specialists they add, the greater number of people you have to interact with, the more complicated your life becomes, and the harder it is for you to ever put all those pieces together. So the sicker the patient, the fewer the professionals you should have to interact with. And what we're seeing now is that hospitals in the United States are creating an index so that when you have a certain level of health complexity or a certain level of social complexity, then you will be assigned a person, a coach, a navigator who will help you to get through the health system, making it easy. Another one is this one, which is really thinking about how do we respond to the patient. I was in this hospital in Singapore, and I said to them, tell me the thing that you're proudest of. And so they brought me over and they showed me this sign. It says 861 restraint-free days. I was in a dementia unit in a hospital, 30 patients, seriously ill with dementia. And they said 861 days with no restraints. So I said, how did you do it? And so they brought me over and had me stand there. Where do you think I am? I said to them, what is this? And they said, the number one cause of a nurse putting a patient in restraints was when the doors to the unit opened, the patients with dementia just automatically got up and started to go out the door. So they made the doors look like a bookcase. Those are the doors to the unit. And they put a book on every patient's bed, and not one patient got up to try and go through the doors. So it was, instead of saying, you're not safe, I'm going to restrain you, they said, why did you get up? What was the root cause of that prompt? And then they changed the prompt so that they're keeping the patient safe without restraints. I think that's a brilliant way to think about using some of these principles. And I think really importantly is joy in work. I think we've got to take care of ourselves. You don't have such a severe problem here as I'm seeing in other countries, in England, but it still is pretty global a problem. When I look at what constitutes joy in work, professional people say it's about gratitude. Isn't that something? It's not about you making me happy. It's the thanks that I get from making you well. It's about hope. It's about an awareness of abundance instead of living in the tyranny of the or. And it's about a deep satisfaction from serving others. So the more that we can use improvement principles to create joy in work, the faster our tempo for change is going to go. If you come to visit IHI, or when you come to visit IHI, I hope you all do, when you walk into the Institute, the first thing you see is this sign on our door. It says, we will improve the lives of patients, the health of communities, and the joy of the healthcare workforce. And people who come are often struck by that word, like they don't see joy on the wall of a healthcare place very often. But when you leave work every day, this is what you see. There's a little tin bucket, and every day when the staff leaves, each person thinks to themselves, did I have a day of joy? Did I make progress? Did I make a difference in someone's life? And if so, they take a silver bead out and they put it in the tin bucket. If they had a day of setbacks, if they had a day of frustration, of delays, and they're stuck at home, they take a brown bead out and they put it in the bucket. And every single day, we measure the number of silver beads, the number of brown beads, the ratio of joy to setbacks. And then we sit every week with the staff and talk about what gave you joy and where were the setbacks. And we're running PDSA improvement projects every single week to increase the joy of the healthcare workforce. These people work really hard. They're flying all over the world. They're teaching people under very difficult circumstances. And if they don't have energy, they're not going to be able to do it. So you might feel like this sometimes. Hugh and I were talking about this morning, that oftentimes when you're at work, you're exhausted and falling asleep. And then when you're at home in bed, you're wide awake thinking about work. But this is the world that we live in so often. So I think it really is incumbent upon us to think about how do we use these improvement methods, not only for patients, but also for you. And I would encourage you, when you're thinking about your, what am I going to do for next Tuesday, to develop an improvement project for yourself. Develop a project that will use all of the methods that you've learned here on you. It might be that you want to exercise more, or you want to sleep more. It might be that you want to accomplish something substantial. I used improvement tools when I wanted to climb Kilimanjaro. It was 20,000 feet in Africa, and I had never climbed a mountain before. So what I did was I set improvement goals, and every single week I made sure that there was some time when I would be walking in order to get ready for Kilimanjaro, and I made it. And I think it's so important for you to find your own joy, because if you don't have it, you won't have the energy that you need to improve care for patients. Work in healthcare is tough. It's one of the only occupations I can find that's physically demanding, emotionally draining, and intellectually challenging. So do take care of yourself. And then part of taking care of yourself, I think, is taking care of your health. And so on the healthcare side, I'll end with a story about health. You know that the WHO, as an example, defines the social determinants of health. The other side, not healthcare, but health. They say it's the conditions in which people are born, grow, live, work, and age. And then they put ... including the health system. We're sort of like an add-on at the end of what determines health. And when you think about it, I'll often show this diagram. These are the social determinants of health. And when I show this to healthcare leaders, you can see them all looking in like, well, where am I? And I have to put a little red circle because that's healthcare's contribution to health. So if we want to make ourselves healthy and we want to make our communities healthy, we have to look outside of the typical healthcare system because that's the only progress we'll make if we use only the traditional health system. So I'll end today by talking about one of the projects from our 100 Million Healthier Lives campaign, and that is a project that we started in Chile. We were asked to come in to a project in Chile because the obesity rates in children were increasing dramatically. United States used to be the fattest country in the world, and then Mexico overtook us, and Chile is right behind. And so they came in, asked us to come in and use improvement methods to make kids healthier. So we went to all the doctors and nurses in Chile, started talking with them about how do we improve health, how do we make the kids fitter. And they said, what are we going to do? We see the kids like once a year. How can we possibly have an impact on kids' weight? So we said, well, where are the kids? They're in school. Let's go to the schools. So we went to the schools and we found out that they weren't in school either. The absentee rates were unbelievable. There was no pressure on kids to go to school at all. So we created a driver diagram, a system map, and we said the first thing we need to do is to get the kids to school. And so we're going to decrease absentee rates by 20%. And we said in order to do that, we have to work with the kids' motivation, the parents' motivation, and the school teachers. So we developed primary drivers and secondary drivers for each group. For the parents, we created this board. It's a whiteboard that's right inside the front door of the school. And when you walk in, each kid has their name on the bottom of a column. And every day when they come to school, they get a red dot. So each kid then goes and puts the dot on their column. When the parents come to pick up their kids, they're seeing variation in attendance, which they never saw. They never knew that their kid didn't go to school as much as the next. So they started having conversations, and it truly motivated the parents to try and get their kids' columns to be as high as everybody else's. The kids, we gave them their own motivation. We gave them crowns when they showed up for a week and certificates when they showed up for a month. And we taught the kids PDSA cycles, so they started running their own improvement cycles. And for the teachers, we gave the teachers report cards instead of them giving the kids report cards. This is how you fare with everybody else this is your grade for getting, because the teachers had no incentive to get the kids to school, and now they did. Once we got them into school, we could start working on obesity. So the first primary driver for health was to decrease them drinking sugar-sweetened beverages and increase their water consumption. They have PDSA cycles. You can see the first one was making water available in the classroom, and the second one was banning Coca-Cola and sugar-sweetened beverages from the school. The third one was developing a simple child measurement system. So every kid has their picture in a little shape on a wooden dowel. And when kids come into the classroom in the morning, their picture is at the bottom of the wooden dowel. As they drink water throughout the day, they get to pull their shape up to the top. And every day, each kid knows their job is to run PDSA cycles until they can easily and reliably drink enough water to get their shape up to the top of the dowels. The kids love it. They used to only drink Coca-Cola, and now they only drink water. My favorite one is this one, where every classroom has 3 plants. And the school teachers each morning come in and they pour water into one, they pour Coca-Cola into one, and they pour nothing into the other. And these 2 die, and this one thrives. And so it's a real visible way to show the kids what happens to you when you drink Coca-Cola. And the school teachers now have run charts and control charts up on their walls, and you can see the pretty rapid decreases in sugar-sweetened beverage consumption and the increases in water consumption. So this was just the first PDSA, and now we're still down there working on health. But it's a way to think about your own health, or it's a way to think about your kids' health, or it's a way to think about engaging with schools in your community to make sure that we're working upstream to prevent problems. So I mentioned yesterday the importance of curiosity, that in my old days of being a CEO of a hospital, I used to hire for IQ. I used to hire people who were really smart. And then I said, I also need to hire people who have a high EQ, emotional or empathy quotient. And I think you can see why I care so much about empathy now. It's a critical ingredient to improvement. But now I hire for CQ. I hire people like you, people who would say, I'm going to give up 2 days to come to a conference and learn from other people how I can make care better. That's high CQ. And so keep thinking, walking, asking questions, because it's going to be the most important thing that you can do. When you think about your team, when you go back, there are 4 things I'd recommend. One is think about how you'll innovate, and then think about how you'll spread. But perhaps one of the things that might be holding you back is you say, I'm too busy. So I'm going to perhaps introduce a new word, and that is exnovate. Do you know exnovation? Exnovation is you stopping and getting rid of all the junk in your life, all the waste in your work, all the stupidity in your daily lives that consumes your energy. And when you start to think about your daily life as possibly having waste in it, you will find so much that you can exnovate. The more you exnovate, the more energy and time you have to innovate. So as you go through your day tomorrow, be thinking, is this adding value? Do I really need to do this? Because the more you exnovate, the more energized and the more curious you'll become. And finally, think about undiffusing. We always think about spread and diffusing best practices. But when a best practice proves not to be best anymore, when our science tells us that a new guideline or a new procedure is better, or a new drug is better than an old one, do we consciously go back and undiffuse the old stuff? Not in healthcare. We keep adding and adding and adding, and we never go back and erase. So the 2 tools I want you to think about taking back with you are exnovation and undiffusion, because they'll give you so much energy to change. So as I wrap up, I think the essence of you as change leaders are these: keeping people well. That's preventing kids from drinking Coca-Cola. Keeping people safe. That's all the things we've been talking about. It's preventing Robbie from dying from a medical error. It's respecting all the assets that the patients and families bring. Listening to my sister when she says there was a relationship between the last DPT vaccination and Robbie's symptoms. Make it easy and really build your own joy. And as you build your own joy, as you do improvement projects on yourself, you will have so much energy to give to others. So as I wrap up, for the secret of the care of the patient is in caring for the patient. And I think we need both empathy and new processes in order to make the kinds of changes that you all, I'm confident, are going to make. Thank you for everything you have done, and mange takk for all you will do. Thank you.
Thank you so much, Maureen. I've been listening to you for 2 full days now, because I've also been to your session for leaders, and we had dinner, and I keep learning every minute. So I'm truly inspired, and I know everybody else is. So thank you so much.
Thank you.
Nå skal jeg avslutte. Jeg skal bruke 2 minutter, men jeg har en bønn. Kan dere sitte de 2 minuttene? For jeg har noe kjempeviktig jeg må gjøre, og da trenger jeg at alle sammen er her. Jeg vil be sekretariatet om å komme opp. Og mens de gjør det, så kan jeg si at vi sender en evaluering på mail i det dere går ut døren. Og det kjempeviktig for oss at dere svarer på denne evalueringen, fordi vi driver jo med forbedring, og hvis vi skal bli best på å bli bedre... Nei, hva heter det? Hvis vi skal bli bedre på å bli best? Nei? Ja, det vi har snakket om i 2 dager som ikke jeg husker lenger. Ja. Så vi helt avhengig av at dere gir oss feedback, både positiv og negativ feedback, sånn at vi kan ha en enda bedre konferanse neste år. Jeg tror jeg skal gjøre det så kort. Jeg håper hun som har mistet jakken sin, at hun har fått den tilbake. Og at dere husker på å kjenne i lommene når dere går, at dere ikke har en fremmed lomme og noen fremmede bilnøkler. Disse menneskene dere ser oppe på scenen nå, de som, hvis dere syns at dette har vært en god samling, og jeg har hørt masse positive tilbakemeldinger, så det på grunn av disse. De har stått for kommunikasjon. Ja. De har altså stått for all kommunikasjon, markedsføring, alt det praktiske, alle parallellsesjonene, det faglige innholdet i parallellsesjonene, middags, vippbord, underholdning, ja, jeg vet ikke hva. Og noen av oss vet hvor mye arbeid som ligger bak det. Det en helt rå gjeng, og de fortjener en applaus til. Vær så god. Vel hjem, og håper dere får en trygg reise hjem. Takk skal dere alle sammen.